Good afternoon. How's everybody? So I'm Gary Slutkin. I'm a physician and an epidemiologist. I'm actually trained in infectious diseases, infectious disease control. And I spent most of my life working on issues like tuberculosis and cholera and AIDS. I spent about 10 years overseas. And I'm going to tell you just a little bit about that. But I want to put violence into that context. And there's three main things that I want to do with the time period that we have. And then John is going to join me, and a violence interrupter, a new kind of health worker, Tim White, is going to join us, and we're going to speak for a while together. First, I want to put forward, in a way, the science behind the fact that violence is actually a contagious disease. And secondly, show how treating violence as a contagious disease has already been demonstrated to have very powerful results. And thirdly, and that's really the transform idea, is to transform this for us into a health problem in a way that the health sector, how many of you are involved in the health sector? The health sector now begins to take a much more major role, really steps up, and in fact leads in the future management of this issue. So I learned much of what I know in refugee camps like this. This is a Somali refugee camp where we had 6 doctors for 1 million refugees in 40 camps. And this is where we learned to develop universal health care, not to the highest level of care, but to be able to reduce mortality actually in just 2 or 3 years through the use of tens of thousands of community health workers. New categories of paraprofessionals. It's also where I learned how to really control the spread of infectious processes, in particular tuberculosis and cholera. And then when I moved over to World Health and began to work on AIDS, in particular with the Uganda program, kind of learned the lessons of how to do behavior change to scale. I'm reminded, and I want us to be reminded, by our own history. And this is a painting of plague, 14th century, when we humans had epidemics of plague and typhus and leprosy and all kinds of things that we don't see so much of anymore. And people didn't want to go to these neighborhoods, and people were dying rapidly, and the people themselves were being blamed. Sound familiar? And why were they being blamed? It was because we didn't really know what was going on. What was going on were, of course, invisible processes, which we now know as microorganisms. And as I'll show a few minutes forward, there's invisible processes going on in the brain that cause both copying, imitation, social belonging, and hypervigilance and hyperagitation that are processed and cause the contagious nature of violence in a biological way. However, when this got figured out, we were able to put it in the past. But before that, we were dragging widows around the moat and putting people in dungeons. Many of these problems, like plague, smallpox, yellow fever, are now in the past. But again, why? Because they became scientifically understood. We transferred ourselves from a moralistic understanding of these problems to a scientific understanding and applied new scientific approaches. These are, in fact, scientific problems. Perhaps all problems of man are really scientific problems. So the elephants, the big elephants that caused tens to hundreds of millions of deaths over our centuries, were, of course, the great infectious diseases and violence. And we're still left with this one elephant, which has caused a lot of problems. And it sits in the middle of our healthcare dialogue, yet we're not exactly paying attention to it as if we should be taking care of it. And it's an elephant because it is the #1 or 2 cause of death among young people. In other words, in the US, #2, in many of our major cities, #1. For young people, this is their cancer or heart disease. This is what they think they're going to die of, and this is what they do. No one paying attention in the health sector. It's someone else, some other sectors taking care of this, we think. In our health policy boardrooms, are we paying attention to this? Even when it's in our face. Case of completely misdiagnosed problem. Possibly the largest medical mistake. So what we actually have is a contagious disease. And there's population and individual characteristics of all infectious diseases. And the main population characteristics are these 3. The first is what really led me to start to think about this in this way, because I was used to looking at clustering of, for example, cholera epidemics or AIDS epidemics, as this one is a cholera epidemic in Bangladesh. And here was one of the first types of slides I was shown, or maps I was shown, about the problem in Chicago. Very similar type of clustering, hotspot mapping, where the most transmission is occurring with concentric circles. Just a clue. What about the type of waves? Well, there's standard types of epidemic waves. This is, again, an infectious disease epidemic wave. It's the characteristic standard epidemic curve. What you see is a big outbreak of cholera and then a secondary wave. Secondary wave, this is what we call point source. The secondary wave is because a new group of susceptibles became exposed. Susceptibles exposed. This was because new refugees came into camp. This infectious disease, violence or killings in Rwanda, shows the same characteristics with a secondary wave, new group of susceptibles exposed, their exposure being actually having been found when they were previously hiding. And many other epidemic types of curves, these are the US curves, also extremely characteristic because all epidemics consist of many epidemics in time and space, and these waves upon waves are characteristic. Now, the most important characteristic, of course, is transmission. Transmission just means that one event leads to another. And we all know that the greatest risk factor of getting flu is being exposed to flu. Same thing for colds. Same thing for tuberculosis, albeit with a longer incubation period. Not the case for strokes. Sit down next to someone with a stroke, diabetes, don't expect it to befall you. However, the greatest risk factor for someone doing violence is having had violence done to them or their group. There's also a dose-response relationship. This is a study that completely controlled for poverty, race, crowding, and saw the greatest risk factor was exposure itself. And that's what separates in public health an infectious disease from all other diseases, that exposure itself is a risk factor and the dose-response relationship, which this study also showed. Now, beyond that, community violence leads to community violence, also leads to family violence. Persons exposed to family violence are more likely to do child abuse, spousal abuse, community violence. People exposed to child abuse are more likely to do child abuse. Why would that happen? You'd think, I know better, I won't do that. Something's been transmitted. Something has been imitated or modeled that carries on. And then you may or may not know this, but someone exposed to ethnic or political environment, an Israeli or a Palestinian child exposed to violence from, quote unquote, the other side is more likely to do violence to their own family or to their own friends. Why would they do that? Something's been transmitted. So there's transmission across syndromes. As means of transmission, we know something about. Whereas cholera, which I'm showing here, the intake is through the mouth, and then the intestine, as you know, processes it, actually poisoning temporarily and causing dysregulation of salt and water. The violence is transmitted by observation, by witnessing, by what's called social learning, which is taken in by the eyes into the brain, and also by trauma. We're now learning the pathways here, that there's cortical mimicking pathways, more complex than mirror neurons. There's also, it appears, dopamine pathways that cause people to belong and need the acceptance of their peers. And there's also dose-response relationships here and immunity here, just as there is for cholera. In practice, the human being picks up most of her behaviors by observing. Very efficient in evolutionary terms. And then carries on to do what others do. Do these children really think through that they should fight afterwards? Or was it expected of them? Did they need the approval of their peers and avoid the pain of social isolation, which also has a specific brain pathway? So this business of cortical copying, followed by probably dopamine reward pathway mediated following, and then the hypervigilance and people going off fast. What are you looking at me for? Which is actually injury. And these results in a spiral of increasing involvement and epidemics. And this has been reviewed by the Institute of Medicine, which is now showing this more clearly to be a health problem, meeting the dictionary definitions of disease, both medical and general dictionary, and the medical and general dictionary definition of contagious. So what does that mean for treatment? Well, it's good news because we know how to interrupt the spread of things. We interrupt transmission, then we have to find out who might transmit next, and then we work on social norms. And for tuberculosis, of course, we have to find the people who are causing the largest problem and put them on treatment. In our world, we need to find people who are about to do a shooting, whether it's because someone looked at their girlfriend or shot their son or owes them money or something of this nature. And for this, we have a new category of worker called the violence interrupter. This is a health worker looking for new impending cases, just like someone looking for new cases of SARS or flu. We then have to find out who, not tonight or tomorrow, might shoot somebody or is planning to, but who's at very, very, very high risk because of their associations, because of a number of known, calculatable risk factors. And then we put another category of health worker around them, who we call behavior change agents or outreach workers. And this allows us to begin to do the interruption of the spread and the longer-term management that the outreach workers do. So this begins by mapping. This is standard disease control, just like the way you do TB control or HIV or STD. Detection and interruption by interrupters, very, very highly trained, go through an enormous training course in detection, in buying time, cooling down, validating complaints, reframing. Detection and interruption also occurring at the hospital. So we have a disease control system going on by the health department in the community, and then we have the hospital connection, where people who show up in the hospital Should they live, we need to prevent them from relapsing, just like someone with asthma or some other condition, and coming back again. Then with the community connection, preventing the retaliation that's expected, that people on their cell phones are usually already planning in the emergency room for the shot person. And these are the outreach workers, and they manage people who are at very, very high risk in a similar way to the way in which we managed out tuberculosis patients for 6 to 24 months. Just what the treatment is slightly different, and much more obviously in the realm of behavior change. They work in teams. And then the last part of this is shifting norms, which requires multiple messengers, group processes, changing social expectations, community responses, public education campaign, and a lot of this stuff mirrors the way that sexual behavior change work was done in Uganda, which was for many years the only successful program to reduce high-risk sexual behavior. And then you have a shift in norms, and this becomes a whole system. An entirely different way of managing this problem than the one that's usually shown on television. Now, we first tried this in the worst police district in the United States, in West Garfield Park in Chicago, about 12 years ago, got a 67% drop in shootings and killings in the first year. Since then, this has been replicated 20 times. It's operating in 15 cities in 8 other countries. This is a different community showing the rapid drop in shootings per month with this method. Here's the first 6 communities. All the way to your left is an average of 6 zones. And the next 3 are 3 comparisons, grouped comparisons of similar rate, neighboring zones, or city as a whole. So here we were averaging 45% with the cure violence method. Some neighborhoods were getting 70 or 80. The next 8 communities, and then the next 4. Before and after, hotspot mapping. And now there have been 3 independent evaluations of this method. One that was done by the Justice Department, which was a 7-year study with a 10-year baseline. Time series analysis, 100% drop in retaliations in the setting of a murder in 5 neighborhoods, 40 to 70% drops in shootings and killings, all told, and other methods looking at other intermediate effects. The Baltimore replication showed a 30 to 50% drop in shootings and killings. And now this is being used in other countries. We're working in Honduras and Trinidad, Colombia. We're getting very strong results in Hanover Park in the Cape Flats in South Africa. The method was adapted using mobile phones to amplify, to reduce violence in the recent Kenya elections. And I have 2 staff members who just came back from the Syria-Turkey border, starting to meet with some of those groups to discuss the thinking, the understanding of violence as an infectious process, and the ideas of trying to anticipate, prevent, keep your friends from doing it, and things like this. So a few years ago, The Economist called this method the approach that will come to prominence. This is a health method being done by the health system. The New York Times has been calling this, has been talking about this in the context of, is this in fact a virus? A film was made about this work, and these are the cities that are doing this. Now, 3 cities, and gradually more, New York City, Baltimore, and Kansas City, the health departments are now managing this. There's an enormous advance, and other cities' health departments are now looking for the resources to begin to put this into play. And these are the countries that are working with this now. So it's another way of us thinking about this is to break down some of these categories too, because they kind of diffuse into each other as well. This is a health problem. Violence is a health problem. Calling it a public health problem doesn't just mean that it has health effects. It means that we in health have a lot to offer here to manage this problem correctly so that we get behavior change, so that we get interruption, so that we have a system, a database system for working on this. We're the group, the field that knows about changing norms, that knows about behavior, eating behavior, exercise behavior, smoking behavior, sexual behavior, violent behavior. They have something in common? Yes, their behavior. So we can begin to shift our view from, and this is intentional medieval text here, from a prior way, an ancient way of looking at this problem in terms of what the people, the way to think about the people and the responses, into a more modern and scientific view that this is in fact contagious behavior, well documented now by dozens of studies. The methods also, we have about 15 or 20 years of research on even some of the brain mechanisms. We have proof of concept and replications that show that interrupting events and behavior change and changing norms as an epidemic control system reduces violence reliably. And so it's also important for us to develop a new language. There's various words that are frequently used on television and otherwise around violence. You might be able to think of them, like words like crime or criminal or things like, these are embargoed words for us. Our words are not judgmental words, but they're words that have to do with the science of this, the health aspects of this. So the health sector is needed to step up. And that's really what ourselves and the Robert Wood Johnson Foundation and others that we're working with are really kind of moving into now, is enrolling the health departments to do the disease control work, enrolling the hospitals to do the both interruption and connection with community for preventing the relapses and for preventing the retaliations, and also getting the other health professionals involved now into all the other sectors that are involved with this for doing the behavior change work. Health sector. Thank you.
Thank you so much.
Thank you so much.
Please sit down. And welcome your colleague out here who is an example of exactly what you were talking about.
Here you go, Tim.
Come on, Tim.
Tim.
So, a couple of basic questions. First, Reverend.
Hey, well, how you doing?
Great to see you.
Hi, great.
Come on and sit down.
All right.
This is Tim White. Tim, how long have you been with Cure Violence?
8.5 years.
So Tim started as a
Violence interrupter.
And now?
I'm a national trainer for Cure Violence in the 15 different cities that we are in.
Let me get a couple of things. We're going to see this in action, though, in just a couple of seconds here, and I think you'll get a sense of the public health dimensions. Distinguish for me, though, from your perspective as a doctor, how is violence different from crime?
Crime is a legal construct. It's a decision. For example, let's just think about drug use, for example. You could decide that drug use is a crime or isn't. You follow me?
Right.
So it's some group's decision about what they want, frankly, to arrest and prosecute about. It's simply not the way we think in health. Example, someone on the street, I'm switching a little bit here from violence to drugs, but it makes for a cleaner example.
Sure.
Someone on the street out of his mind on drugs, crazy out of his mind, making enormous disturbance. Someone comes and picks him up and takes him to, let's say the police show up, okay? a whole series of potentially possible outcomes here could go the wrong way. Let's say this guy resists, insults, punches, whatever, because he's high on drugs. Other possible outcome. Someone takes this guy to the emergency room. It will come out better for him. You follow me? It's a health point of view. I used to work at San Francisco General. We had people coming in as crazy as could be. One of them, I remember when I was an intern, punched my resident. Still, you know, I'm really sorry you did that. We're still taking care of you. It's just an entirely different view of the person. And it's about support and care.
The difference in views, though, I suspect means, and I love both of your insights on this, that there's an inherent conflict between a health view of violence and a law enforcement view of violence. I mean, I don't necessarily get the sense that cops on the street in violent neighborhoods in New York are looking around for, hey, where's the doctor to come and help me out here? I get the sense that they feel like this is their territory, they want to do it alone, and they're great cops in New York and all over the United States, but is it possible to collaborate with law enforcement on a program like this?
Well,
boy, that speaks volumes. That look right there.
No, I just wanted Tim to speak.
In order for the program to really work, you have to have credible messengers to get into the core of the guys who's actually committing the violence, the highest risk. And in order to get close to these guys, to build a relationship based on trust, they got to trust that you can, you know, they can, before an act of violence is committed, they can call on you and say, man, this guy owes me some money. If he don't pay me, Tim, I'm gonna do something to him. He's not gonna call the police and try to get his money. He's gonna call someone that he can trust to see if they can mediate the situation. Or if you have a mother in the house, a son just ran in the house and he looked like he had been jumped on. He runs in the basement, looks under the mattress, looked like he grabbed something and runs out of the house. She's not gonna call the police because she don't wanna put her son in jail. She needs an alternative, and she'll call someone like us, say he's in a white T-shirt, he hangs on Pulaski and Chicago Avenue. Can you please try to catch him before he do something stupid? That's we're credible in that area. People call us for alternatives other than putting them in jail.
But that's just, you know, the point of the hottest moments of where interruption is needed, where the police job is, if something happens, it's their job. Right. But our job is to prevent something from happening.
Before.
So we need to pull this guy back so it doesn't happen. Police sometimes in situations like that doesn't happen so far.
So there's a wide domain where there's plenty of room for both of you to coexist.
Exactly. That's the case. That's the reality.
All right, so take me into the point of interruption experience. What's that like? How do you do what you do?
I mean, well, you collect all the information about the event, whatever the conflict is. Make sure that you got all the correct information, no assumptions. And then you try to bring either two parties together or you do a one-on-one. You might do I might meet with one side and get all the information, what they expect from this conflict mediation and what they're looking for, the outcomes. And then I'll meet with the other side and make sure I do reflective listening. So when I go back and tell the other side that exactly what they expect, either they're going to agree on it or they're not going to agree on it. And it's my job to try to find some common ground where they both can agree that it won't, you know, result in violence.
Do you think of your work more as mediation or more as chilling somebody down, calming them down so that they don't do something that they feel like they have no control over?
I think it's about changing the norms. That's the only thing they knew. It's when we grew up in the inner cities, we ran to fights. When we see someone fighting on the block, we run down there to see who was fighting. Or it was normal for us to see someone fight, or it was normal to see someone shot and run down and look and see who got shot. But now when it comes to new information, new skills, we try to give them new information about how to deal with it. You know, social skills is really not what they should be in our inner cities. They don't, when they see someone looking at them strange, they don't know what they're looking at them for, but they're in a defense mode where they don't want to be violated. And so they got this defense mode and this masquerade that they put on so no one can violate them.
How do you get someone to drop that when they're holding a firearm and have already committed violence and you know how dangerous they are?
When they give us an opportunity to do our job and they see that it works, they rely upon us in the future. They'll call on us when they see a friend that might have a situation going on, and they say, this guy Tim worked with me, man, and I didn't have to do nothing crazy. So won't you give him a call and see if he can work with you on this situation you got going on?
Is there anyone you interrupted that you worked as a healthcare intervener who you didn't believe it was going to turn out positive and it actually did?
Well, it was a situation where we did a hospital response and the guy had already been shot. And he was a well-known guy in the community and looked up to, and he was real violent. And when we went to visit him in the hospital, we did a hospital, that's one of the components of hospital responder. And he was crying, he was telling, you know, that he didn't really want to hear us. Man, I really don't want to hear all that peace right now, Tim. And I was like, man, you really need to think about it, man. I said, you got the power to you know, stop it. I said, it's been going on all summer, back and forth. You can stop this. And then he like, man, I'll let you know. And then I guess he thought about it. And before he came home from the hospital, he gave us a call. He said, man, you tell them if they stay on this side of the street and we're going to stay on this side of the street, they don't have to worry about us no more. But if they cross over this side of the street, then we got a situation. And I went and told the other side the same, you know, what he asked me to tell them. And we stopped it. From that point on, the rest of the summer, there was peace in our community.
Is peace infectious as much as the way the doctor describes violence as being infectious? In other words, does one successful outcome lead to another?
Well, I believe it is. I mean, I'm a product from my community, and I believe that when I started working for Cure Violence, I didn't understand the dynamics of stopping violence. I felt that that was the only way. You have to stay tough. You got an image to uphold, a reputation to uphold. And then when I started to try the new skills and try to be humble, I seen that it works this way too, because now people are starting to pat me on my back for being humble. They say, man, if you can do it, Tim, we can do it. Because we used to look at you as being a tough guy, and now we see you, you know, taking a humble approach. So they, I believe it's infectious, yes.
Can I say something about that? So it's not the idea just simply of violence and not doing violence, or you know, doing high-risk sex or not doing high-risk sex. There's all these specifics to it that have to do with, you know, the role of Tim and the people who he trains, and what they've learned in terms of managing situations and the experience that they have. So it gets broken down, you know, into, you know, validation, cooling down, buying time, getting other people they know. You know, the fact that we're very, very selective in who we recruit, and so that they're known to be talking to the person in the same interest. And then they get good at reframing and talking to people about their kids or about their mom or about their grandma or something like that. And they have a skill set. And I mean, the stories are just unbelievable, but it's very similar to, you get someone who is, you know, emergency medical technician. Now, we didn't have them before. We did ambulance drivers. Now you got emergency medical technicians. They come on a scene, there's someone who is like laying there, not breathing, not moving. What do you do? So if you had the guy sitting here, they ask him, you know, well, how do you manage that situation? He's got a whole bunch of training, he's got a whole toolkit as to what to do, and then he gets better and better and better and better at it. So, and that's what happens, you know, when you're doing epidemic control too. You have to design new categories of workers. Originally, the outreach worker and the interrupter were one, and then we kind of broke it down to two. But they're a whole system. Every community has a manager, supervisors of outreach workers, interrupter group. They're documenting their work. There's all kinds of accountability and metrics, feedback into the system, just like managing any other epidemic. But like the person who gets talked out of it, it's kind of like the person with TB who got treated. I mean, I used to I ran the tuberculosis program for San Francisco years and years ago. Across the street was San Francisco General. They would treat the person with who had TB and send them out. And we'd be chasing this person all over town then, because who else is he going to infect? So we had to, and I trained all those residents and interns and knew them. But still, we had to put a new category of worker into that hospital and into the wards to do the continuity to keep them into the program for the next, it was a year and then became 6 months. But these guys, they continue to shadow, work, babysit, whatever the words they use, for 6 to 24 months on these guys. And then it's also their friends and so on. But it isn't just the high risk, there's another group of characters around who are like the people with TB who have lower grade problem. They're not infecting everybody, but they're going to show up soon. And we find those guys through active case finding. And so it's the whole system that really drops this.
So once again, it's a community devoted to vigilance about something that they understand can get out of hand, and it's making sure that it's not just about the hospital or the emergency room, it's about solving problems, preventing problems out into the community. So it's a network, it's tentacles,
right.
it's a whole guy. Now, you've gotten the flu before, right?
Yes.
Yeah. Now, I hear the metaphor of the doctor here describing the infectious disease. And does violence feel to you like the flu? And does that metaphor mean something to you?
Well, I believe violence it spreads. I mean, if my friend find out that I got shot, he's going to go look for the person who shot me when I was in the street life. So I seen it spread to the point where my whole family is involved in something with another family because of one incident, one interpersonal conflict. So conflict spread. I mean, it's a well-known fact that if someone fights or get into it with your family member, you're going to be there. It's an unwritten rule when gang members get into it that the other gang members got to be a part of it. But it's not just a gang issue, it's interpersonal. It spreads. Anytime that someone gets into it with you and you're at a club and you go to the club with your friend, it's an unwritten rule that you're going to ride with your friend while you're there, even if he's wrong or right. But now we giving new information. Before we get to the club, we'll say, hey, listen, if you can't, don't do nothing stupid because I'm not riding with you on this. Don't put me out there. I already know when you start drinking, you're going to do something stupid. And I'm just letting you know I'm not riding with you. So now we're giving them, equipping young guys with the tools they need to prevent it before it happens. Everybody got a crazy cousin. Everybody got a crazy friend. And you need to know.
Everybody has
everybody.
Who has crazy cousin? Raise your hand. A crazy friend? Raise your hand. Okay, great.
So you need to know your environment, and the people in our community knows who are the potential shooters, who knows the highest risk, and the only way you're going to find out are you a credible person where they'll reveal that to you. This guy here, you need to keep an eye on him because he's a ticking time bomb. You probably want to constructive shadow him and build a relationship with him and let him know that there's other methods.
As you talk, it seems that your infectious disease metaphor is exact. I've been to the Somali refugee camps that you worked in as a journalist, probably different years, but I do recall, to prevent infectious disease in a refugee camp, you have people who are making sure things are clean, making sure that the waste disposal is taken care of, that those vectors are dealt with. You have all sets of jobs that are all involved in the exact same thing. It's not simply the doctor, it's not simply the vaccination, it's water purification, it's all of those things. Why doesn't the political system see violence in this way when it really doesn't take that much convincing?
You're talking about in the U.S.?
Yeah.
Well, there's a mindset problem here, in a way. I mean, frankly, I feel like I'm trying to tell people that a whale is a mammal because it looks so much like a fish. But the U.S. is kind of stuck on very moralistic thinking about problems, and also very emotional responses to problems. These two categories, I've not seen them solve problems historically. I've not seen moralistic solutions to problems or emotional solutions to problems. They need to be kind of scientifically broken down. But America's kind of in a very high anxiety, high fear, and highly moralistic, and it's an individualistic country.
And so when the president talks about Syria and the civil war there and asks every American to make a decision about what we're supposed to do, you don't see politics necessarily, you don't see policy, you see a kind of global disease transmission.
Yeah, I mean, what's going on in Syria, not funny, but I mean, it's been spreading. It's been spreading for 2 years. In fact, you know, the violence spread throughout the region over the last 2 or 3 years. I mean, I've got slides on this that just show, you know, it's spreading. I mean, we saw this also, you know, in the London riots. You know, it went from, you know, 1 city to 24 in 4 days. World War II is nothing. World War I, nothing but a 4-year, 15 or 20 million person epidemic of, you know, one after another building out. You just collapse this in time. You know, countries behaving as people or gangs or groups. Yeah, this is the behavior of this problem. This is a contagious problem. If you look at any of the curves, you look at the maps, the graphs, if you dispassionately take yourself away from the reasons, get rid of the reasons and just look at it. Because if you ask people what the reason is for doing this or that, you don't get the right answer anyway. If you were asking people, I mean, if you know, 200 years ago, you know, why are you coughing? You know, I said, well, I have this invisible microorganism in my lung. No, they probably wouldn't say that. Do you follow me? Because they don't know that.
When my kids are fighting and I ask them why, they actually don't give me a rational answer either.
No, because the behavior actually occurs first, and then the reason comes afterwards, frequently. So the new social psych books are turning this upside down. The behavior is modeled, and then people do what other people do. The dominant force, the dominant invisible force of human behavior is what you think other people are doing. I mean, look at how we're all behaving here. We're doing exactly what everybody else is doing. We're sitting at tables on chairs, very quietly. No one's standing up on a table dancing.
Later tonight.
Yeah, I mean, everybody is kind of conforming. I mean, do you think I want to wear this? You know, so, you know, so this is the expectation of others that, you know, I have an awareness of it. But I mean, like, the number one reason for this,
I didn't make you wear the tie. I'm not going to take the response for that.
It's much more collective.
Yeah.
But I had an epiphany. When I was working at World Health, we were doing all these studies on sexual behavior in the world. And so what is the number one predictor of whether someone uses a condom or not, besides whether they're available? I said whether, you know, they know that AIDS is there, they know that AIDS is very, very serious, they know that you can die of it, this. No, it wasn't. It was whether they think their friend uses a condom. But that isn't what they said was the answer. That was the thing that matched up. Do you follow me?
Right.
But I went, this is how people are making a decision as to whether or not they're going to use a condom. But it's invisible. But public health knows this. That's why, number one reason moms breastfeed if their friends breastfeed. Immunize your kid if your friends are immunizing your kid. And we use that in public health. We use moms to talk to moms about breastfeeding. We use sex workers to talk to sex workers about HIV. We use refugees to talk to refugees in the refugee camps. We use people who used to be engaged in the problem, who know people, to be involved with violence interruption and behavior change.
Health is culture.
Yeah.
Culture is health. Gentlemen, thank you so much.
Thank you.
It's really beautiful.
Thank you.
Thank you very much.